Uh, Good evening, viewers. Good evening, colleagues. I'm Professor Ekwedigwe Kenneth Chinedu, a consultant obstetrician gynecologist and a fertility physician. I'm the moderator for today's event. And today is going to prove to us to be a very important day because we'll be discussing a very topical topic, which is polycystic ovarian syndrome, which is, we all know that is one of the commonest causes of anovulatory infertility in our environment. And we have with us for the discussion a very senior erudite scholar in the name of Professor Christian Chigozie Makwe, who will be taking care of the topic and also educating the house. I believe that at the end of the day, we're going to go home with a lot of knowledge. I believe that it's going to be so insightful. Then today with me is my co-moderator, a well-known and foremost research embryologist, Mrs. Inigwe Oja Samuel. She's going to co-moderate with me. She's done so much work in the field of embryology, which is a key component of assisted reproduction. So I'll be handing over to her for brief announcements before we now move on with continue with the program for the day. So Mrs. Inigwe, please, you have the floor. Okay. Welcome and thank you.
Thank you very much, Professor Kenneth. On behalf of AFRH, I would like to welcome everyone again. So before today's presentation, I would like to run through the ongoing activities in AFRH. As we all know, the AFRH conference is fast approaching. So to all the AFRH conference delegates, this is to remind us about the forthcoming 15th edition of the Association for Fertility and Reproductive Health Annual International Conference, and it's taking place on September 24th to 26th, 2025 at the prestigious Lagos Oriental Hotel, Lekki Ekpe Expressway, Victoria Island, Lagos. Of course, we all know, as it has been announced, that the early bird registration ends on the 30th of June 2025. So let's do well and register promptly. And also, the call for abstract submission for this year's conference has commenced. So it is time to showcase your experience and knowledge by writing an abstract. Kindly check the flyer. The link provided will give you more details. And of course, the conference registration and payment validate consideration of call for abstract submission. Now, for this year, there is a tweak to the abstract submission, which is a cash prize of 100,000 naira, courtesy of Mrs. Bobo Kayode Memorial Foundation, which will be presented to the best abstract submitter during the conference. So submission deadline for abstract is on Thursday, July 31st, 2025. I would like to urge every one of us to kindly follow AFRH on all our social media handles as displayed on the screen. Thank you, and over to you, Professor Kenneth. Over to you. Over to you, Professor Kenneth.
Yeah, can you hear me?
Yes, we can hear you loud and clear.
Now, okay, so I'm going to do a brief on Professor Makwe. So, just a few minutes, please. Let me get his citations, okay? Okay, so I'm going to give a citation, and a brief citation of Professor Makwe, Christian Chigozie. Professor Christian Chigozie Makwe is a professor at the Reproductive Endocrinology and Fertility Regulation Unit of the Department of Obs and Gynecology, College of Medicine, University of Lagos, and a consultant of obstetrician and gynecology at the Lagos University Teaching Hospital, LUTH, Idi Araba. Professor Makwe holds a degree in medicine, public health, business administration. He's a fellow of both colleges, both West African College of Surgeons and National Postgraduate Medical College of Nigeria, Faculty of Obs and Gynae. He also holds a Doctor of Medicine, MD degree from the National Postgraduate Medical College of Nigeria. Professor Makwe is a seasoned researcher and is involved in so many research work, both nationally and internationally. He has several national and international collaborative research projects with over 75 publications in peer-reviewed journals. Currently, he is a collaborator in the polycystic ovarian syndrome phenotypes in unselected population study group. He's a recipient of several awards and research grants.
Thank you, Professor Kenneth Ekedibe, for that.
Congress on Hysteroscopy. So he's the current head in the whole Africa, globally, in the Global Congress on Hysteroscopy. So he's a very, very charismatic fellow, very amiable, very loving, and also someone that is also willing at any time to share knowledge with anybody. He's a mentor extraordinaire. So Professor Makwe,
Good afternoon, everyone. Thank you, Professor Kenneth Ekedibe, for that brief introduction. I don't know if I'm audible.
Yes, you're audible, so we can hear you.
All right. I don't know if my slide is still visible to everyone. The moderator, just to confirm.
We can see it.
All right. So, good afternoon, good evening to everyone, to my colleagues, senior colleagues, and other collaborators present in this webinar. Thank you for joining. I want to use this opportunity to thank the AFRH Training Committee for inviting me to the webinar series and to give this lecture. Titled Polycystic Ovary Syndrome and Fertility. Basically, they wanted me to talk about the updates on medical and surgical options of management. Though I'm very happy to do that, I think I will expand that to talk about all the necessary updates that we all need when it comes to polycystic ovary syndrome and fertility. As usual in presentation like this, I wish to declare that I have no conflict of interest to declare. We're going to follow this outline, a little bit of the learning objectives, background, an overview of the pathophysiology of polycystic ovary syndrome and its clinical features, and how to make a diagnosis of PCOS. This is very important because there have been a lot of updates and refinements of the criteria for diagnosis of PCOS, because you cannot manage a condition that you have not properly diagnosed. And that is very important that we all pay attention to that. And these are based on evidence that is available to all of us. And based on those evidence, there are also evidence-based management options available to women who have polycystic ovary syndrome. And we'll focus more on the fertility issue and how to manage women with infertility in PCOS. And we will conclude. What is important is that at the end of this lecture, we should all be able to understand the clinical features of PCOS and how to establish an accurate diagnosis of PCOS. And also, we should be able to list or outline the fertility and the non-fertility issues associated with PCOS and understand the concept behind individualized care for women with polycystic ovary syndrome, and also the way to manage their fertility-related issues. Polycystic ovary syndrome, as we all know, is a complex endocrinopathy with significant long-term reproductive, metabolic, dermatological, and psychological health impact. This disorder is very common in women of reproductive age. It's been estimated that the prevalence of PCOS is between 5 and 15%. But I can assure you that most of these data are exclusive of people in sub-Saharan Africa, where we lack data on prevalence of this condition. Where estimates has been made, it is shown that the PCOS as a condition is global in its distribution. So it causes a global public health concern because one, it causes significant health morbidities, and two, it costs a lot in terms of economic impact to the individual, society, and the economy at large. Just to give you an oversight about those morbidities, polycystic ovary syndrome is related with reproductive issues, and by reproductive issue, we talk about the chronic anovulation that polycystic ovary syndrome causes, the irregular cycles associated with it, the issue that you notice polycystic ovary morphology in this individual, and the fact that they tend to have hyperandrogenism, meaning high level of male hormone called androgen. All these contribute to the subfertility or infertility observed. But these reproductive issues are just a little portion of all the issues that people with polycystic ovary syndrome suffer. They also have metabolic issues. They tend to have insulin resistance. They tend to have obesity, dyslipidemia. Some of them end up developing diabetes, which would have started as pre-diabetic condition, if not well managed, will end up over years as diabetes. They're also predisposed to cardiovascular conditions, hypertension, cardiac diseases. They also have psychological problems, depression, anxiety, negative body image, especially for those who are obese, low self-esteem, psychosexual dysfunction, where because of their low self-esteem and body image, they might also have issue with engaging with sexual activity. And this can also contribute to the infertility we observe. They tend to have eating disorders and also poor quality of life in general. In addition to this, they also have issue with sleep because they have what we call obstructive sleep apnea. They also have dermatological condition where you have issues with hirsutism and also issue of acne, which are all things they go through and they suffer from. I did say that polycystic ovary syndrome is a complex endocrine disorder. But this flow diagram is just to show you how complex this is. You can see all the arrow pointing different directions. Central to this is hormonal changes. So it's a disorder's endocrinopathy. And what are the hormones that are affected? You have the androgen. This condition leads to increased level of androgen, and the patients with this condition also have hyperinsulinemia. Their insulin level is also increased. And despite that, they have some resistance to insulin, and that's why they are also predisposed to diabetes. All these changes are what results in the issues or the clinical features we see in patients that have PCOS. The androgen leads to hirsutism, which is the male pattern hair growth that we see in female. It leads to acne. Those androgen and the insulin resistance all contribute to the menstrual disturbance we see, and the fact that long-term they can develop diabetes mellitus and cardiovascular risk. And some of these features are things that end up presenting with the psychosocial issue that we see: the body image, the self-esteem, depression, and the anxiety we see in these individuals. But in terms of occurrence, certain features are more frequent in people with polycystic ovary syndrome. Top on the list is the irregular menstrual period. This irregular menstrual period is an indirect sign of what we refer to as oligoamenorrhea, meaning they have infrequent ovulation or absent ovulation, and that leads to their period being infrequent or absent, okay, because they are not ovulating. They also have excessive male-like terminal hair growth, which we refer to as hirsutism, where they tend to have what we call hormone-dependent hair growth. And this hormone-dependent hair growth, we find them in the chin, on their chest, on their upper and lower abdomen, on their back, on their upper arm, and on their thighs. And they also present with some fertility or infertility, because when they have frequent or infrequent period of anovulation, they are not able to conceive, and therefore they tend to present with challenges of infertility. Some of them might also have scalp thinning of their hair, called alopecia, similar to what you see in men, or they present with acne or pimples. About 44% of them will present with obesity or overweight. Some of them will have dermatological changes like dark patches on their flexion area called acanthosis nigricans. They can also present with insulin resistance, where if you do their oral glucose tolerance test, you notice that they can have abnormal value that will suggest pre-diabetic. Some of them might even be diabetic. Their insulin level baseline, if you measure it, is relatively higher. And this is something that you see in 50 to 70% of individuals. They also tend to have disorders of lipid profile, what we refer to as hyperlipidemia. And sometimes they come with a combination of both the hyperlipidemia, insulin resistance, obesity or increased BMI, and other things that will consider what we call metabolic syndrome, which are issues that we need to deal with. And if you look in terms of frequency, you notice that top on the list is the irregular cycle, the male pattern of hair growth, and the insulin resistance. And people feel that these are cardinal features that we must look out for in patients with polycystic ovary syndrome. Even though we know the features of polycystic ovary syndrome, over the years, it has been a challenge establishing or making a diagnosis of polycystic ovary syndrome. And that's because over time, diagnostic criteria has changed. From in the 1990s, where you have the National Institute of Health in America, say you only needed hyperandrogenism and oligoamenorrhea to diagnose PCOS, to the Rotterdam criteria that was established in 2003, that said you only need 2 out of 3 criteria, where you have hyperandrogenism, oligoanovulation, and polycystic ovary morphology on ultrasonography. People like the Androgens, SS, and PCOS Society have also tried to define. Even in 2012, the NIH came back with a consensus that they felt that there might be need for us to even have different phenotypes of PCOS, where they have phenotype A, where someone has all the 3 criteria present, or you have phenotype B, where you have only hyperandrogenism and oligoamenorrhea present, or type C, where you have hyperandrogenism and polycystic ovarian morphology, and type D, where you have oligoamenorrhea and polycystic ovarian morphology. You can agree with me that over the years, with the changing definitions, it's obvious that the prevalence of this condition will be different in a different region, depending on the criteria they use. It's also be possible that some people will be misdiagnosed or undiagnosed because of this change in definition. But there's something I want to point out here, that for you to say somebody has a diagnosis of PCOS, you must always remember to exclude conditions that can look similar to PCOS or can mimic PCOS. And these conditions, that some of them can give you oligoamenorrhea, are things like hyperprolactinemia, where women have high level of prolactin when they are not pregnant or breastfeeding. And because of that, some of them might also have milky discharge from their nipple called galactorrhea. Or when you have thyroid disorders, hyper or hypothyroidism, or when you have the non-classical congenital adrenal hyperplasia as a syndrome or Cushing syndrome. Because if you do not exclude this, some people will be diagnosed as PCOS, whereas the real diagnosis would have been hyperprolactinemia, hyper or hypothyroidism, or non-classical congenital adrenal hyperplasia, or even Cushing syndrome. So it's always important to remember before you label an individual as having PCOS, that you will have excluded this condition. But more recently, which is where the updates come in, the 2023 International Evidence-Based Guideline for the Assessment and Management of PCOS tried to refine these criteria for diagnosing PCOS. They wanted to make it clearer so that when we talk as researchers, we talk as clinicians, we talk as physicians, we are speaking so that when we say someone has PCOS, really that person has PCOS. But one thing was obvious is that in order to make a diagnosis of PCOS, you need to understand that you need to distinguish an adult individual from an adolescent because of the way they present. In an adult, diagnosis of PCOS will be based when you have at least two of the following three criteria that has always been there all from the time of Rotterdam criteria. One is oligoanovulation, meaning they have infrequent ovulation or no ovulation at all, or they have hyperandrogenism. And here, hyperandrogenism can be clinical, where we use the modified Ferry-Mangalway score to say the person has clinical hyperandrogenism, or biochemical hyperandrogenism, where we use the level of the androgens in the individual's blood to say that it's high, beyond the female range. And if they have either polycystic ovarian morphology, it's important for you to note that the polycystic ovarian morphology referred here is when you have the follicular number per ovary to be 20 follicles or more. Unlike the initial Rotterdam criteria in 2023 that was using 12 follicles, antral follicles or more. Now we use 20 antral follicles or more to say somebody has polycystic ovary morphology. Something that is also new in this update is the fact that in place of ultrasonography in adults, you can use the level of anti-mullerian hormone to also make a judgment that somebody has PCOS, meaning that if somebody has, let's say, for example, has oligoanovulation that has been confirmed either based on the irregular cycle or based on the fact that you have done has mid-luteal phase progesterone and it's low. If that person, in addition, has elevated anti-mullerian hormone, okay, and you have excluded other conditions that might mimic that condition, you can actually say that that person has PCOS. This was not there in the previous criteria for diagnosing PCOS. In the case of an adolescent, the diagnosis is usually based on just oligoanovulation and hyperandrogenism. Why is this so? If I know my colleagues would have also observed this, if you have the privilege of scanning people during adolescent period, less than 20, you will notice their ovaries tend to be polycystic in nature. So if you're using the fact that having multiple antral follicles is a criteria in them, you will overly diagnose them. And that is why for the latest updates, you do not need ovarian morphology in adolescents to make a diagnosis of PCOS. You only need evidence of oligoanovulation and hyperandrogenism, which can be clinical or biochemical. In order to also make it easier, the pathway for people to establish the diagnosis of PCOS, Because in the past, people were subjected to a barrage of investigation or tests in order to make a diagnosis of PCOS. Current latest evidence-based updates shows that you can follow an algorithm that makes it efficient for you to optimally diagnose PCOS without doing extensive investigation. And this will start with step 1. If somebody presents with irregular cycle, which I will later explain what is defined as irregular cycle, and also has clinical evidence of hyperandrogenism, meaning you have assessed the level of hirsutism using the modified experimental weight score, and the person meets the cutoff for you to say the person is hirsute. If you now exclude the other causes that may lead PCOS, you can also say that this person has PCOS. Let me explain. For this step 1, somebody has irregular cycle, has features of hirsutism. You don't even need to measure the blood androgen. You don't need to do measurements for total testosterone, free testosterone, or all that. You don't need it. If there's evidence of clinical hyperandrogenism as defined by hirsutism, you don't need that blood test. You can make that diagnosis, but you need to still exclude conditions that can relieve PCOS. And you can go to step 2, where the individual does not have features suggestive of hirsutism. That means there's no clinical hyperandrogenism. In this individual, because she has irregular cycle, no clinical features of hyperandrogenism, what you need to do is to test the individual's blood to see if the level of total testosterone, free testosterone, and other androgen are elevated beyond the acceptable level for females of her age. If it is elevated, we also still need to exclude conditions that may make PCOS. Having had irregular cycle and biochemical hyperandrogenism, you can confidently say that the person has PCOS if there's no other explanation in terms of other causes that can relieve PCOS. You can also go to step 3, where the person has only irregular cycle. You have checked, there's no clinical hyperandrogenism, meaning the person is not hirsute, no hirsutism. You have also checked the blood, and you also found in the blood that the level of androgen is normal. For that person now, these are the person, if that person is an adult, you want to request for a scan to be done, preferable a transvaginal scan using modern high-definition scan that will give you quality. And it's recommended that the transvaginal probe you are using should be able to do, the probe frequency should be able to give you 8 megahertz or above. If you now do the scan and you have polycystic ovary morphology, which you have 20 antral follicle or more in at least one ovary, in addition to the irregular cycle or having one of the features of clinical or biochemical hyperandrogenism, and that person is an adult, you can now say that person has PCOS. But if that individual that has only irregular cycle or has just features of hyperandrogenism is an adolescent, in adolescent, scan does not make a difference because if you look at their ovary is polycystic. So for those individuals, you cannot do scan. But because they only have either irregular cycle or just clinical or biochemical features of hyperandrogenism, they only have one. You need 2 at least for you to say the person has PCOS. Because they have one, these individuals that are adolescents, you can just say, consider them at risk of PCOS so that when they become adults and you reassess or reevaluate them, by doing the scan now, it might contribute for you to labeling them as PCOS at that stage. And it's important for you to understand and distinguish these aspects of here. So if you use this algorithm, you will see how simple it is to diagnose PCOS, and it doesn't require you to do so much extensive tests, and you don't even need to do everything at the same time. Rather, you will do it in a stepwise approach that minimizes the cost to that individual, the cost to the health sector, and also the cost to the whole community or nation. So this algorithm has been proposed and is being recommended as a way to diagnose PCOS. The next thing we need to understand when we say irregular cycle, based on the 2023 International Evidence-Based Guideline, what it means that you need to take note of the individual, whether she is how many years post-menarcheal is she? Menarche is the first menstrual bleeding and girl child or an individual has. So if you have somebody that is more than 3 years post-menarche, and she's not yet perimenopausal, what will you say? What we will call irregular cycle is when her cycle length is either less than 21 days or more than 35 days, or alternatively, if in the whole year she has less than 8 menstrual cycles per 24-month period, you will refer to that lady as having irregular cycle. However, for people who are between 1 and 3 years postmenarcheal, that definition is slightly modified. Yes, less than 21 days is still irregular, but some of them have to get more than 45 days for you to say they are irregular. Why? Because following establishment of menstrual flow at menarche, the hypothalamic pituitary ovarian axis is not yet well established. So there's always a possibility that periods can be irregular and it's considered acceptable. But when that interval goes beyond 45 days, between 1 and 3 years, that is considered abnormal and defined as irregular menstrual cycle. If that person is within 1 year of attaining menarche, you can only say she has irregular menstrual cycle if her period has not come after 90 days, which is 3 months, okay? That is when you can say she has irregular. And it's important for us to note these differences in the definition of irregular menstrual cycle. The other thing that's important we have used to define PCOS is hyperandrogenism. And I told you there are 2 ways to assess hyperandrogenism. One is to do clinical hyperandrogenism, where you have features of what we call hirsutism. And the score or the tool that we use to assess clinical hyperandrogenism, the most acceptable one is what they call modified Ferry-Manjawi score. And in the established guideline, they say for you to say somebody has clinical hirsutism, the score must be between 4 and 6. Why is it 4 and 6? Because they notice ethnic variation. In some places, females are more hairy with dependent hair. And for those people, you need a higher cutoff to say they have hirsutism. I can tell you that in the nearest future, this cutoff of 4 to 6 will be modified to 4 to 8. Why? Because there are newer evidence published this year that shows that for different population, the cutoff for you to say that somebody has clinical hirsutism ranges from 4 to 8, such that for Black people, sub-Saharan African Black people, the cutoff should be 7 and above, not even 6. For Italian whites, it should also be 7. And for Iranians, women, white Iranian women, the cutoff should be 8, meaning that you can't even use 6 for them. And I expect in the nearest future, based on this latest evidence, that this guideline will further be updated. The next thing is biochemical hyperandrogenism, where you don't see features of hirsutism and you decide to measure the level of androgen in the blood. The first line test that you need to do are the total testosterone, the free testosterone, the calculated free testosterone, and the free androgen index. This might sound easy, but it's not. Why? Because the technique that you use to measure the androgen must be high-quality, reproducible technique. And what is recommended is the lipid chromatography and mass spectrophometry. I can tell you that equipment is not readily available in Nigeria. For the current research that we're doing on PCOS, we had to ship our sample to the United States of America to ensure that those steroids are measured correctly so that our results and our publication can be world standard, okay? When these first line androgen are measured and they are normal, you can now go to the second line androgen, which is the androstenedione and dihydroepiandrosterone sulfate, which are also other androgens that might be elevated in people with suspected polycystic ovary syndrome. Now let's go to the definition of what we call polycystic ovarian morphology on scan. This, in the previous documentation before 2023, used a cutoff of 12, but for now, we use follicular number per ovary that is 20 or more in at least one ovary. You don't need to see it in both ovaries. Just one ovary having 20 or more antral follicle. What do we mean by antral follicle? These are follicles that are usually between 2 millimeter and 9 millimeter in diameter, okay, in their main diameter. So if you have 20 or more, that is what we call a polycystic ovary morphology. Or you have an ovarian size. You measure the ovary in 3 dimensions, that is 10 mils or more. That is also a picture of polycystic ovary morphology. But mind you, for you to say the ovarian size is 10 millimeter, 10 mils or more, you must also make sure that one, there's no dominant follicle. These are follicles that are 10 millimeter and above. There's no cyst. These are cystic structure that are about 30 millimeter in diameter or more. So you need to exclude those things, because if you have a dominant follicle or a cyst, it will make the ovarian volume larger than it is. So for you to say that the ovarian volume is greater than 10 mils, you must exclude that there is no dominant follicle and there is also no cyst. Some people have also advocated that you can also use the follicular number per cross-section. When you take a cross-section of the ovary and you're seeing all those antral follicles, and you're able to count 10 in one section, then you can say that person has polycystic ovarian morphology. However, using these 3 criteria to define polycystic ovarian morphology, the one that is most predictive of polycystic ovarian morphology is counting the number of follicles per ovary. And how do you do that? You have to either use a 2D scanning machine and meticulously count the number of follicles, starting from one end of the ovary, and take a swipe all through the ovary. And as you change, you count till you get to the end. It's a bit difficult, but when you are trained to do this, you see it can be easy for you to count the total number of follicles. Yes, it might have some limitation, but that is one way to do it. The other way, if you have a 3D probe that can do volume calculation and you have the automated thing, they can calculate the total number of antral follicles in a particular ovary just by do one scan and pressing the computer and to generate all the follicles. That will be another easy way to do it. But the important thing that this polycystic ovary morphology they are talking about, you only do it in women who are adults, okay? Not in adolescents. In adolescents, if you check their ovary, it will appear polycystic, and it will not help in any way in making a diagnosis of polycystic ovary syndrome. So now that we know how to diagnose, and we know all the latest updates on the diagnosis of polycystic ovary syndrome, how do we manage this women? The important thing to note is that you need to individualize the care and still be holistic in your approach to management. What do I mean? Individual patients sometimes come with one of the clinical features as the predominant complaint. Okay? So somebody might come with the fact that she has irregular cycle. That is that, but she has polycystic ovary syndrome. She's not desirous of fertility or that. So you need to make sure your treatment focuses on what the patient wants. Some of them might come and their main complaint is the hirsutism. Some might come, the main complaint is the infertility or subfertility. You need to do that. But in managing their reproductive issue or their fertility issue, you should also not forget to manage the patient as a whole. If the patient has metabolic issue, you should manage it. If the patient has psychosocial issue or psychological issue, you should manage it. If you properly understand the ramification of PCOS, you will now understand and appreciate the fact for you to properly manage the patient that has polycystic ovary syndrome, you will ideally need a multidisciplinary team of doctors or individuals to manage the patient properly. You need obstetrician gynecologist in terms of the reproductive issue that has to do with irregular cycle or subfertility or infertility. You might need an endocrinologist when you're talking about people who have diabetes or pre-diabetic or people who have issue with obesity. You might need the services of the dermatologist for those who present with hirsutism or with acne, or you might need the services of a psychologist or psychiatrist for people who present to you with issues of anxiety, depression, low self-esteem, and all that. And if they have developed things like cardiovascular hypertension or other things, you order need other specialists. Even for those who have what we call obstructive sleep apnea, there are specialists who are called sleep therapists that can help them. There are some people who, in addition to, in an attempt to help them with their body mass index or to correct their overweight or obesity, they might need a physiotherapy to help them. So you must always think holistic when you see somebody that has polycystic ovarian syndrome. Don't just choose what you want to do. Because she says irregular cycle, you just correct her cycle and leave the metabolic aspect and leave the psychosocial aspect or the psychological aspect. You must treat the patient as a whole. The other thing that's important is that in some part of the world, if they come in contact with somebody, even if you have reproductive issues, let's say she presents with infertility, her BMI is 44, some of them will not offer them treatment except they correct the metabolic aspect, the obesity, the other issues, the pre-diabetes, until it's corrected. You don't start getting them pregnant. And that is very important. So once you diagnose PCOS, assessment and management should address both the fertility and the non-fertility issue. By that non-fertility, I mean the metabolic, the cardiovascular, the dermatologic, the sleep, and the psychological issue. You must address all of them. It's well appreciated that you might not be responsible for all the various disciplines, but you can link that individual to all the other physicians that help manage them. When I have the opportunity to present PCOS to endocrinologist conference in Nigeria, one of the things people ask, how do you do it? I'm lucky because I'm in a teaching hospital. I have the service of a lovely consultant dermatologist for my dermatological issues. I have the services of very good endocrinologists to help me with the endocrinological issues. So for me, it's easier. But for some of us that are in private setting, we need to establish that multidisciplinary team around you to know where to refer them to get the best optimal care for whatever other issues they might have that is related to polycystic ovarian syndrome. So this is really a lifelong health plan that focuses on their health lifestyle, because lifestyle modification comes into play, as we'll see later. Prevention of excessive weight gain is important. Optimization of fertility is important. And sometimes when they come because they have soft fertility or infertility, it gives us an opportunity to offer them quality preconception care and assess their preconception risk factor and modify the risk factors that we have identified that are modifiable. And therefore, we can now be able to prevent and even treat all the other clinical features that they present with. So because the topic is PCOS and fertility, I'm going to come down to the fertility management, infertility management in people with PCOS. When it comes to infertility management in PCOS, there are various options available. First on the list is lifestyle modification, behavioral strategy. They have to set targets. Weight loss or weight maintenance is not an easy task. People want to set goals in terms of diet, in terms of exercise, and it's a build-up of all the strategy that allow them to reverse or even correct some of their body mass index that issues they have when they're overweight or they're obese. Following this, some of them that come with infertility, when you have done the first line, lifestyle modification, might still require medical therapy. And by medical therapy, what is the main problem in people with PCOS? The main problem is they have oligoanovulation. And this is a chronic thing. It's not just one episode. It's over months. And that might be the only thing that is making them to get pregnant. Okay? So when you have properly evaluated a couple who has infertility and every other thing is normal, and the only problem is that she's not ovulating, we have various medical options for the management. One is that we can induce ovulation using oral ovulation induction agents. We're all familiar with it, most of them, letrozole, clomiphene citrate, and even the use of gonadotropin injection. It's important to note that the first line medication for ovulation induction for people with PCOS is letrozole. It's preferred for several reasons. One, it's more likely to cause monofollicular ovulation compared to clomiphene citrate. And its mechanism of action also help to make sure that the cervical mucus is much more favorable to the sperm for those who are going to have timed intercourse and other form of treatment. So letrozole is considered first option or first line treatment before you go to clomiphene citrate. It's been documented that up to 80 to 93% of women on letrozole will ovulate. A much lower percentage or proportion might get pregnant. People will see 60 to 80%. The same thing with clomiphene citrate. About 60 to 80% of people on will ovulate, and about 60% of those who ovulate will get pregnant. Where these two oral medication, letrozole and clomifene fail, you can go ahead to use FSH, either as urinary product or a recombinant to stimulate follicular development, okay, and enhance ovulation. In this case, most time you will require to use HCG as a trigger to finally trigger ovulation when the follicles have gotten to their pre-ovulatory size. Some people say greater 16 millimeter and above, okay? There's also other medical treatment that can help people with PCOS. These are usually aimed at helping them to modify their metabolic tissue, and that is the use of insulin sensitizers like metformin. Metformin is not an ovulation induction agent, but it helps to improve the likelihood of ovulation, sometimes when used alone, and it also improves outcome in terms of clinical pregnancy and reduce miscarriage in people who are using it when used properly. You also have the option of in vitro fertilization or assisted reproductive technology in general. If the ovulation induction does not work, then you can step up to in vitro fertilization. In some places, you also have surgical options like laparoscopic ovarian drilling that can also help. How does it work? Just by putting some current on the ovary during laparoscopy, all right, helps to change the ovary to switch from producing more androgen to less androgen that will favor the production of estrogen and also the production of progesterone if there's ovulation. So the laparoscopic ovarian drill is meant to alter that hormonal change, mainly by altering the androgen produced from the ovary. Another surgical option available to patients with PCOS is bariatric surgery. For some of them, you might try all the lifestyle modification with diet, exercise, and it's not working. Their BMI is so high. In some developed countries where they have all the resources, they might offer these patients bariatric surgery, and usually they will wait for their weight to stabilize. Usually this will require them waiting for up to a year before they can now come back to start dealing with their fertility issue, okay? Because you don't want them to still be losing weight when they get pregnant. So most people advise that after the bariatric surgery, their weight should stabilize and they come to normal or close to normal BMI before you start planning them to get pregnant. And sometimes this might take up to a year for the effect of the surgery to be optimal and for their weight to be stabilized. There are other things that have been suggested in literature, the use of vitamin D and inositol. These are still considered a little bit experimental, even though it's widely used in most parts as adjunct to treating women with PCOS. Another interesting thing that's happened in the space of polycystic ovary syndrome is the fact that the 2023 International Evidence-Based Guideline has also brought out an algorithm for infertility, all right? Infertility algorithm for people with PCOS specifically. And what is this algorithm? It's also meant to refine how we manage people who have infertility and also have PCOS. One of the things is that you need to establish the diagnosis of PCOS, that's first. Then you also need to do all the other baseline investigation that you need to do if you are evaluating somebody with infertility. By the way, infertility means the failure of a couple to achieve pregnancy despite regular, unprotected sexual intercourse for 12 months or more. If they come, even if the woman has features of polycystic ovary syndrome, it's good to evaluate them using our baseline test. Check, make sure that tubal patency can be documented or confirmed. Check the husband's sperm, and now make up your mind that the only problem in this couple is anovulation due to PCOS, okay? And if she has any of the other issue, metabolic issue and other things, try to treat them. And that's what they meant by optimize their preconception health and lifestyle. If they need to lose weight, that is time to do it using behavioral strategy, diet, and exercise. Haven't done that. If everything is fine, the woman is in optimal health, the next thing to do, which is the first line medical treatment, is what I told you earlier, the use of letrozole to induce ovulation. And you can encourage them to have timed intercourse, or you can do intrauterine insemination as the case may be, based on the indication, all right? Or sometimes some people might also escalate that and use clomiphene citrate. Why? It is not in all countries that letrozole is licensed for use as an ovulation induction agent. And in most of those countries, clomiphene is the one that is recommended in those countries. So if that is what is recommended in your country, you should use clomiphene to induce ovulation. I know in this part of the world, we don't have those strict NAFDAC regulations. Most of us prescribe letrozole and clomiphene citrate. But if you are using clomiphene citrate, it has also been shown, instead of using clomiphene citrate alone in people with PCOS, it is preferable for you to use clomiphene citrate with metformin. The important thing to note when you use clomiphene citrate and metformin that once you do a pregnancy test and she's positive, okay, it's always good to stop the metformin because of concern of teratogenicity in the early stages of pregnancy, okay? And some people go ahead to even just give metformin alone, observe for some time before they even add the clomiphene citrate, just to see if some of them will resume ovulation spontaneously with metformin alone. But mind you, I said metformin is not an ovulation induction agent. Or if clomiphene does not work and letrozole does not work, some people want to escalate to gonadotropin. When you go to gonadotropin, the risk or the chances of having multifollicular ovulation becomes higher. There's always need for proper follicular tracking, especially the same way you're going to do for letrozole and clomiphene. But for gonadotropin, it's more important that you do follicular tracking. And for patients with polycystic ovary syndrome, when you want to use gonadotropin releasing hormone, follicular stimulating hormone, gonadotropin, it's better to start with low dose and build up gradually. Because if you do high dose, you can recruit so much follicle that it becomes unsafe for her to have timed intercourse or even IUI because of the number of follicles. Some protocol will say if you have 4 or more follicles that are pre-ovulatory, you should not trigger the woman and you should not make her get pregnant because all the pre-dominant follicle, the dominant follicle can rupture, that's ovulate and fertilize, and the person will come up with triplets or quadruplets. So you don't want that kind of situation. And that's why they say when you use gonadotropin, the chances of multifocal pregnancy is very high. And we also know that the cost of gonadotropin is higher. So this also increases the cost of care for this patient. If this does not work, then these are patients that you can now consider IVF as a third line. Mind you, the gonadotropin we are using, low dose step up, is considered second line when the oral agents used for ovulation induction does not work. That is letrozole and clomiphene citrate. And I advise all of us to always go back to this algorithm and look at it. It is very helpful and it can just minimize the way and the approach that we use in managing infertility in people with PCOS. This is just an overview of the different doses for letrozole. Most people will just start with 2.5 and adjust the dose based on response because we are scanning the individual when you start this ovulation induction agent to see that their follicle are developing and gets to maturity and there's ovulation. Where you do not achieve that, you're allowed to adjust the dose. The same thing for clomiphene citrate. Gonadotropin injection too, it's important that you start low dose and build up gradually instead of going to the high dose of 150 to 225 that we use conventionally for IVF. So for the surgical pain, laparoscopic ovarian drill is also considered the second line for some individual, and just consider forming for most strategy, just have 4 punctures on both ovaries at a depth of 3 to 4 millimeter with a 40 watts energy current lasting for 4 seconds. And for most people, that will do. The beauty of laparoscopic ovarian drill that when they achieve ovulation, that is sustained and they don't need to take medication. And with that, they can get pregnant. And for those who have morbid obesity, bariatric surgery or metabolic surgery are usually advised. And I told you, it's always good to wait till their weight is stable before you start to sort out their fertility issue or make them get pregnant. Because following the surgery, there will be a progressive decline in their weight going towards the normal BMI. And that is not, when that weight is not yet stable, that's not the time you want to achieve pregnancy in them. And when you escalate to IVF, this is usually because the first line and the second line has failed. And for those women, depending on the causes, if just PCOS alone, the conventional IVF will work. For some centers, the ART that they do is just ICSI for everybody. That will also be applicable. But mind you, when you are doing IVF for this patient, it's always good to also do low-dose step-up approach, okay? So that you don't produce so much follicles and predispose them at risk of OHSS. And we know that once you start getting above 20 follicle, up to 20 follicle or more, the likelihood is high. But the good thing now with ART in patients with ovarian syndrome, that we have an option. You can use an antagonist protocol to make your treatment flexible. So that because some patients, no matter the dose of gonadotropin you give them, they will develop HSS. So I've been privileged to manage 2 clients that came from the United States. And they always told me, the doctor wrote it in the notes, she's at risk of OHSS. And she said, this is a horrible experience. She had 2 IVF in the United States of America. She both developed OHSS. And I told her, if we want a protocol that will make you want to do OHSS, we'll do antagonists so that if the follicles are there, I will trigger with agonists. And in the second cycle, immediately do a frozen embryo or embryo transfer. And that's what we did. And she has a beautiful set of twins. So, but she didn't have OHSS. And that's only strategy. I've also used it for 2 of my clients too. The same thing. If you give them gonadotropin, they will develop ovarian hyperstimulation syndrome because they have background PCOS. So one of the strategies that you can use that can be safe is to do stimulation and use agonist trigger, and that you follow do if you are using antagonist protocol. And you will not transfer in that cycle. You will do freeze all. You freeze all embryos generated from that cycle. And in the subsequent cycle, either immediately or at the subsequent time, transfer the embryos and you can still have good and excellent results. That is it. At this current, based on current evidence, there's no difference whether you use agonist or antagonist in terms of live birth or ongoing pregnancy. There's no difference, okay? But the use of antagonists just gives you an edge that you can convert that cycle to a freeze-all site strategy, where you don't need to transfer immediately. And mind you, when they have even mild OHSM, by transferring the embryo, if she gets pregnant, the HCG produced by the ongoing pregnancy will worsen the OHSS. So you can also have delayed or late onset OHSS in this individual. So one of the best strategies I've seen for those who are at risk of it is to do an antagonist cycle. And if you're running into that risk because you are generating so much follicle, convert it to a freeze-all strategy and freeze-all embryo you have generated. In conclusion, there's evidence-based guidelines that are up to date for the assessment and management of PCOS, and this will help you in early diagnosis without wasting resources. It will help you with comprehensive risk assessment and a holistic approach to the care of this person. You're not just not thinking about getting them pregnant, fertility alone. You are thinking of the whole individual, all the problems she has, and you are tackling them. And the best way to do that, if you have a multidisciplinary team that will help you so that the patient gets the optimal care that she requires. And that will always lead to an optimal outcome. So where you do not have this team of experts, try to establish one in your various facilities. For infertile women with PCOS, it's always good to optimize fertility and ensure you take the opportunity that they are coming before they get pregnant to offer them appropriate preconception care. This is highly recommended because you can pick other issues that you might need to sort out, because even increased BMI has been linked with increased pregnancy loss, miscarriages. By just making them lose weight, you can ensure that pregnancy gets, all right? It's also good that you use that infertility algorithm that has been evidence-based, developed by evidence to manage your PCOS. It will streamline your investigation and ensure accurate and prompt diagnosis of the patient. And this is considered best clinical practice at the current time. There are several options of management available to women with PCOS. You need to individualize your choice of treatment based on what the patient is presenting, okay? And if the low-cost techniques, which is like ovulation induction with letrozole or clomiphene will suffice, kindly use that. Not everybody, because they have PCOS, you just escalate to IVF, or try the low-cost one and the simple one. And for some of those women, that is all they need. And their experience is that sometimes, following your induction of ovulation, they get pregnant and deliver. In subsequent pregnancy years, they might just take it spontaneously without needing your help. So, but it's important to know that it's always good to start with low-cost technology before escalating to the high-cost ARTs that might be the final result in some of the women. If you decide to do ART, remember, these women are at risk of OHSS. Thank you for listening. I'm open to your comment, questions, and observations.
Thank you so much, Professor Christian Chigozie Makwe. Indeed, you have done justice to this topic. I think from the comments so far, it's been excellent presentations from virtually everybody. So you've done great. It was quite insightful. It's also a way of helping some of us to memorize what we read during our residency days. Okay, so it's a refresher course, more of. So, and it's quite rich and loaded with information. So thank you very much. At this point, we'll open up the floor for questions and answers. So we'll look at the questions and questions that people ask and see whether you can give a response to them. Okay. So on that note, I think we look at some of the questions. So I'm here to see one. Okay, somebody asks, does the hyperandrogenism undermine the success of ovulation induction and IVF? And do you give drug to suppress the androgens?
Yes.
Okay, that is the much I can see here.
Okay, so thank you for that question. Yes, in the past, they are concerned because we know, like, when the androgen levels are reduced, like when you do the laparoscopic ovarian drill, it helps to improve fertility. But the question is, do you actively reduce the androgen in this individual? And what options do you have in terms of reducing androgen? Based on current evidence, there's no recommendation for you to use anti-androgenic medication for people who are desirous of conception when you are talking about fertility. In non-fertility related issue, like people with hirsutism and other things, anti-androgen have become useful and have been prescribed to do that. But in terms of fertility, the evidence does not support that you should actively use medication to suppress the androgen. Yes, androgen can provide part of the things, a kind of a resistance to ovulation, but we don't actively suppress it in patients that are going for fertility, even though there's that some people, like, one of the reasons they give where you have failure of ovulation in patients that use oral medication and even failure of ovulation using some gonadotropin is because of the people link it to high level of androgen. But when you have that high level, is there anything you do specifically that has been shown to work? I don't know of any, even though I've read in literature where people have used things like dexamethasone to inversely cause some upper center suppression that will further reduce the likelihood of production of the androgen from the ovary. But these studies have not been yet evidence-based. What I've presented is what the evidence says that we should do and what is acceptable in terms of best clinical practice. But I'm open to people's experience and what they do in trying to suppress androgen, especially in the context of fertility. In non-fertile, in people who you are managing for because they have hirsutism or acne. Yes, anti-androgens have been useful, but not in fertility-related issue. But I'm open to experience from senior colleagues, and we can share what works and what doesn't work.
Okay, thank you very much. There's another question here that says, how high does anti-mullerian hormone level need to be to suggest polycystic ovarian syndrome? How high does anti-mullerian hormone level need to be to suggest polycystic ovarian syndrome?
All right, so the important thing is that in places where you use anti-mullerian, they have what they call age-specific cutoff. So you have to use the age-specific cutoff for that population. What it means that these people have done studies, they have gotten either in 95 percentile for that population for each age-specific group, so that if you say age 20 to 25, this is the range. But mind you, this is only done in adults, people who are 20 and above. That's 1, 2. That you have the highest value when you are age 20 to 25. And that is why for you to make sense of the value, it has to be based on age. So you use age-specific nomogram for AMH for that population. If that is above the age-specific, then it is high. But I am not aware of any age-specific nomogram for us here. These are research questions that we can further explore to get what is the age-specific nomogram for our own population. For the most developed country, they can give you the age-specific nomogram that you can use. This age to this age, if it's above this, is considered high. This to this is considered high. The same way as you go towards perimenopausal, towards the extreme of towards menopause, the values tend to be low, and this low value are also based on age-specific value. And I noticed in the past, we just tend to adapt whatever we say abroad without having our own local context to establish the cutoff.
Okay, another question says the polycystic ovarian syndrome, what dose of antagonists is recommended?
So we use the standards. If you're using cetrorelix, we use the standard 0.25 to suppress. The issue is most people want to start early, like on day 5, instead of the standard day 6, to use the antagonist. And you can use it 4 to 6 days or longer, depending if you're using an antagonist cycle. I don't know if that is what the person wanted to know about. 0.25 milligram or 250 micrograms.
Hello?
Program, 250 microgram daily. Once you get, so there are 2 ways to do it. You can do what they call the fixed protocol, which is what I've just described. You start with the protocol. Once you scan the patient regularly and you start having follicle 13 millimeter and above, for most things, you just start the cetrorelix and the antagonist.
Okay. Thank you. Thank you for that. Then the next question says, hello?
Sorry, I'm back. Sorry, my network logged me out and I'm back. Sorry, can I have the next question?
Yeah, the next question says, I think the person joined late in the lecture, but the question says, the letrozole or clomifene, please clarify which to use first in PCOS patients with infertility.
Okay.
Or
so the first line, the first line where letrozole is approved for use for ovulation induction is letrozole. And I said that because most times it tends to cause more of monofollicular ovulation. And also its cervical status or cervical mucus is more acceptable to the semen or the sperm, So most people prefer that compared to clomiphene citrate. But in some countries, letrozole is not registered for use for ovulation induction. And I said in this part of the world, we seem not to have those strong restrictions. I've seen physicians and specialists prescribe letrozole and also clomiphene citrate. I think that answers the first line. Letrozole is considered first line. And you just start 2.5 milligram and you adjust based on your response, meaning that if you start with the lower dose, just the same way you do like clomiphene citrate, start with 50, you scan, and if you are not able to generate follicle, pre-ovulatory follicle, and there's no ovulation, you might want to increase the dose. So from 2.5, you can go to 5 and up to 7.5. The same thing with clomiphene citrate, you can go to from 50 to 100, then to 150.
Thank you, Professor Makwe. Thank you so much for this enlightening lecture, for this very insightful lecture. I think you indeed qualify for an erudite scholar and erudite professor of
Thank you.
So at this point, I want to call on our boss, the president of AFRH. I know he's fully present, he's fully on ground, listening to his voice and his men talking. So I want to call on Professor Prayer to give us one or two things or make one or two comments before I now call on my co-moderator to also reemphasize the earlier announcement she made before we now close the curtain. So Professor Prayer, you have the floor, sir. My boss, you have the floor. Okay, while waiting for him to come on board, there are so many beautiful comments here, especially from one of us, who is a well-known obstetrician gynecologist, both nationally and globally, as in name of Professor Ogedengbe, Bumi Ogedengbe. My welcome. I didn't know you were here, but I just saw your comment, and you made mention that that he's so proud of the presenter. I'm also very, very much aware that the presenter was one of her mentee. So, Prof,
Yes,
thank you
thank
for
you,
your
Prof.
comments.
I appreciate it.
Thank you for your comments.
She's my mentor and teacher.
Yes,
And she's always
I'm aware
has
of
been
that.
my teacher.
So she's so proud of you. So, Professor Prayer, please. Okay, if he's not forthcoming, he's around. Okay, while I'm waiting on Professor Prayer to come on board, I want to call on my co-moderator, Mrs. Inibi Uja Samuel, to give us recast the update that the announcement she made before on our upcoming AFRH annual conference, and also give us other information if need be. So, Mrs. Inibi Samuel, please, you have the floor. Thank you very much.
Thank you. I appreciate it. Again, a big thank you to Professor Christian Chigozema. We appreciate it for the highly expository presentation. I appreciate you, sir. Okay, so like I earlier mentioned, the AFRH annual conference 15th edition is fast approaching, and we're all expected to do justice by registering. So this year's annual international conference is taking place between September 24th to 26th, 2025 at the prestigious Lagos Oriental Hotel at Lekki Ekpe Expressway, Victoria Island, Lagos. And also, the call for abstract submission for this year's conference has commenced. So the conference registration and payment validate consideration of
Hello.
We have to please check the conference flyer. The link provided will give you more details. And of course, I want to buttress the fact that a cash prize of 100,000 naira, courtesy of Mrs. Bobo Kayode Memorial Foundation, will be presented to the best abstract submitter during the conference. And of course, submission deadline for the abstract is on the 31st of July, 2025. So please, I would like to urge us not to miss a chance to share our research work so far so that others can learn from our insight. So you can do that by even submitting your abstract today. Thank you. Over to you, Professor Kenneth.
Okay, my boss, thank you so much, Mrs. Sinibi. Thanks for those information. They are quite helpful. Please, if you've not registered, go and register for the conference. We can't be registering for international different countries. Meanwhile, the one inside our Shokoto is suffering. Please, it's a clarion call. Please make sure you are registered for the conference. Thank you very much. So at this point, I'm calling my boss, Professor Prayer. I think he's back online. So Professor Prayer, please, you have the floor. Thank you, sir.
Hello, good evening, everyone. and the well done moderators. Professor Makwe gave an excellent presentation, and you can see the quality of people we have in our system. We always look for external resources, but we have them in here. I was at Japan IFFS meeting a few months ago, and all the current information that was provided on PCOS were given by Professor Makwe. So thank you, Professor Makwe, for an excellent presentation. You've spoken about registration, the conference and all, and God willing, we'll have a fantastic conference in Lagos and subsequently an international conference in Abuja next year. Well done, and thank you, everybody.
Okay,
Thank you, Mr. President.
Thank you, Mr. President. Thank you so much. So from the AFRH administrative house, the secretariat, do we have any information for the house before we wrap up the show for the day?
No further information.
Okay. So on this note, we call it a day. We thank everybody for making our time to join the webinar. The webinar is getting stronger and better every day.
Oh, yes.
So that means if you are coming here to address us, make sure you are very well prepared. So I'm happy we are getting better, and we are getting better and better every second. So thank you, everybody, for coming. Thank you once again, Professor Makwe.
Yeah.
Have a nice day. Bye.
Thank you. Bye, everyone.